Still okay, great. So we are back now for a further session where we will discuss the role of liquid biopsy in cholangiocarcinoma. So it's my pleasure to introduce the co-chair, who needs no introduction. Mitesh Borad is a medical oncologist at the Mayo Clinic Cancer Center, where he directs the GI Cancer Gene Therapy and Oncolytic Virus Lab, and he serves in many committees, including the International Cholangiocarcinoma Research Network that is currently co-chairing. So I'm happy to invite the first speaker. He is Francesco Facchinetti. Francesco is currently a postdoc in the Dana-Farber Cancer Institute in Boston, after having his medical degree at the University of Parma in Italy, and then his PhD in Paris in 2022. So thank you, Francesco. And he will be giving a talk about technical insights into circulating tumor DNA, which platform to use.
Good afternoon, everybody. It's a real pleasure to be here and to share with you some thoughts about liquid biopsy and ctDNA in cholangiocarcinoma, and I will play a little between the two titles that have been given to me. So in the concept of liquid biopsy, which platform to use, but also when to use it. And finally, the final question that I will try to answer today is how to use liquid biopsy in this setting. These are my conflict of interests. And approaching circulating tumor DNA, we should mention that ctDNA is the most relevant, one of the most relevant elements that the tumor shed into the bloodstream, and we can recognize through a blood sample for potentially early cancer detection, potentially for surveillance of micrometastatic disease, but what really interests us in the setting of clinical practice today is identifying molecular markers in circulating tumor DNA that can inform treatment selection and treatment decision. So my focus will be, again, dealing with the clinical practice right now, and for the treatment selection for patients with metastatic disease. And so, again, we are here to discuss the possibility for, let's say, today's patients. And we are mainly chasing oncogenic events that drive tumor fate and tumor responsiveness to targeted treatments across all the disease course. This will have relevance for what we will see thereafter. And I will try to be as pragmatical as possible, acknowledging that we are in a field where approvals, both from drugs and from companion diagnostics, are really at the edge with off-label utilization of agents and enrollment in clinical trial. Nevertheless, at the end of the day, the main message that I will deliver to you and the main utility of ctDNA in this scenario is avoiding leaving patients behind from a potential treatment with clinical utility, and we are in the field of a precision medicine of precision targeted treatment. This is not a real organized agenda, but I will approach some elements dealing with an historical approach. When we move to the present, we will deal with different platforms. I will focus a bit on FGFR2 fusion detection by liquid biopsy in cholangiocarcinoma, and I will share with you some thoughts about some challenging elements to consider. When dealing with an historical approach, I guess that most of the doctors and of the researchers in the floor have a kind of experience in cholangiocarcinoma, gastrointestinal malignancy, and colon cancer. So maybe you could thought that I'm dealing with the disease monitoring in KRAS wild-type colon cancer with the wonderful work by the Italian group that led to the discovery of KRAS mutations at resistance and how to chase this kind of biologic elements through time, but nevertheless, I'm someone who dedicates the most of his time to the study of lung cancer, and I've already found my paper of choice for 2023, where these researchers compared, from an oncogenic point of view, the molecular landscape of cholangiocarcinoma to the one of non-small cell lung cancer, and I will play a little on this parallelism. And from an historical approach, I started from something real, so from the unofficial, the official site of FDA that lists the validated companion diagnostics tool for solid and liquid malignancy and for solid and liquid biopsy. And it turns out that the first and the most widely, I would say, used not screening, but test for in a liquid biopsy program, in a liquid biopsy setting, was for a resistance mutation in EGFR, T79TM, that indeed don't even dictate the tumor fate. So I'm denying myself for what I've said before. Nevertheless, he really orientated targeted treatment, because this was this major publication that really revolutionized for some a short but very relevant period of time the treatment of patients with EGFR-driven non-small cell lung cancer that at progression to first and second generation TKI underwent liquid biopsy, and a positive results for T790M could address to a third generation inhibitor, osimertinib. And it's important to me to start from here, because this kind of strategy led to infinite discussion of which platform, which how to interpret the report, when to candidate the patient to a liquid biopsy to detect only one mutation. And this historical approach helped me to approach which are the two main categories of platform, let's say, of methods that we can have to process liquid biopsy, a plasma sample coming from patients, mainly so we deal with PCR-based and next-generation sequencing-based at that time when we were looking for EGFR T790M, we were looking for one single mutation. So we prefer to have a very, very high limit of detection to be as much sensitive as possible, but covering only one point mutation. And this is a setting when, in liquid biopsy, we start to think about sensitivity, so reduce as much as possible the rate of false negative, the specificity, reduce the false positive, and the actual real readout that we have in patients is the positive predictive value. So when the marker is present, we have the response to the treatment. Moving to the present, we don't deal with T790M EGFR in non-small cell lung cancer, but approximately 50% of the patients with this diagnosis can undergo a targeted treatment. This means that this targeted treatment can be guided by a liquid biopsy, and so we move to the left, to platforms NGS that can lose a little in limit of detection, still quite high, but can help us to have a coverage that is far wider, so we can cover virtually all the genetic events that are actionable and that are targetable in every single patient. Moving now to the field that in which we are interested, in cholangiocarcinoma, I did the same homework that I did before for lung cancer, let's say, and plasma. And if I look at the FDA approval, I found cholangiocarcinoma in tissue, FGFR2 fusion arrangement, and IDH1 variant, so the companion diagnostic are approval. We then step in the concept of tumor agnostic companion diagnostics that mainly deal with tissue, and last but not least, it is formally approved the plasma validation of NTRK fusion. I take a moment to say that these are the formal approvals, but I'm convinced that the lesson that we have here from and the acknowledgement that we are here for the tissue can be extrapolated in the plasma as well, also taking lessons from other diseases where some relevant markers are approved, their searching and their detection is approved even in liquid biopsy. Because in cholangiocarcinoma we have several activations that we can target, and you in the floor are well aware of that. In green are the ones that can indeed be targeted by agents right now, and dealing with KRAS, we in the lung cancer world, we are quite lucky because we have the KRAS G12C inhibitors, but I'm very, very confident that this will happen also for the other KRAS inhibitors in the other field of solid malignancies. And here, Spencer and colleague listed the activating mutation and fusion seen at least 5% of patients. We know that there are exceptional events, like the one that we have reported 2 years ago, of molecular events that are currently seen in other diseases occurring even in cholangiocarcinoma. And we know that we don't want to leave any patients behind. Again, the transition from formal approvals and treatment applies also to dealing with the treatment. So this is mainly the treatment received by the same cohort that Spencer reported, is a mix of clinical trial, of off-label indication. So this is something, a chapter that is completely open and really at the edge between approvals and off-label and clinical trial inclusion. So, very pragmatic concept. So in which way ctDNA can help us? And from a clinical standpoint, I see two major scenarios of integration with the solid biopsy, with the NGS in the solid biopsy. First scenario, tumor recurrence after curative intent, meaning that surgical material is available. Then the question is open from a practical point of view for having the molecular testing performed, and the scenario number two, the onset of cholangiocarcinoma as an advanced metastatic disease. Really, the situation here to obtain a diagnosis and to perform molecular testing can be extremely variable. Nevertheless, in which way ctDNA can help us can be resumed by the work of Dr. Lamarca, stating that cholangiocarcinoma diagnosis is challenging, and cholangiocarcinoma diagnosis, molecular diagnosis on solid tumor can even be more challenging. So from this standpoint, the fact that taking a blood samples is non-invasive and it's quite a representation of what's happening in the tumor can provide some solutions for having a signature of molecular events occurring in patients, because we are chasing, as we said before, oncogenic events. And so the same things that we saw for lung cancer apply to cholangiocarcinoma, and I take this moment to say that the targeted NGS platform that are commonly used are not maybe the best to assess tumor mutational burden, and nevertheless that whole exome or whole genome sequencing can also go below the 10% limit of detection. These are very technical aspects. And what we have on the market of FDA approved are the two platforms from Guardant Health and Foundation Medicine that differ for some, again, some technical and also clinical readouts. And I really recommend you to go through this table in details, in a work performed by my colleague and friend Damian Vasseur, and approach more in detail one entity that I know a little better that are focused on FGFR2 fusion. Again, this is written clearly in practical consideration that some lesson in cholangiocarcinoma molecular testing can be brought from other tumor types. Nevertheless, FGFR2 rearrangement are challenging to detect even in tissue, can be even more challenging on liquid biopsies. And when I first received the invitation for give this talk, I was quite scared to have to confront myself to try to vehiculate some messages about coverage and difference in platform like this. I have not the competence to go through that. It's only to testify how complex this setting is. And the things that we observed working with Lipika Goyal is that when we use the Guardant platform, let's say the correlation between FGFR2 detection fusion from ctDNA compared to tissue biopsy is less than 20%, and considering that FGFR2 has a plethora of possible fusion partner, this really affects the detection rate. So Guardant is quite good in detecting FGFR2 fusion where BIC1 is the partner. When it's something else, it becomes quite challenging. Nevertheless, always Lipika Goyal in this paper on futibatinib using another platform that is Illumina had better results, because more than almost 90% of the patients with plasma available had consecutive positive liquid biopsy results detecting FGFR2 fusion. This means that even if technology shared even if platforms share the global technology, this is next generation sequencing, high throughput, and hybrid capture, there can be very subtle differences that can lead to different results. And some practical and clinical challenges that you can face in the daily life is there when, for example, on the left, the order of the gene, of the FGFR2 gene and the fusion gene is flipped. So we have, instead of FGFR2 BIC1, BIC1 FGFR2, or when variant allele frequency are particularly low, which significance we can give to these elements. It's difficult to answer. The best readout is the outcome of the patient that in both of the two cases in the situation responded. Nevertheless, this critical and difficult consideration should be discussed together within a tumor board and with experts in the field. One question that I ask to myself is that we can recreate the scenario that I pictured you before for lung cancer. So what we can do is that a way that liquid biopsy can address the treatment beside the first generation of first FGFR inhibitor received by patients, because we know that we have agents that are active after reversible inhibitor. Nevertheless, I came back with my message of sensitivity, specificity, and positive predictive value. Here, I'm a little bit in difficulty because we cannot compare the sensitivity and specificity of liquid biopsy to tissue biopsy, because liquid biopsy performs better in detecting resistance to FGFR inhibitors. So the sensitivity and specificity elements are difficult even to define, and I cannot say that a mutation is present, the patient will respond to futibatinib or relay, or tyrosine kinase mutation are not present, so we will not have a response. So I cannot deliver a clear message. Moving, hopefully, quickly to elements of practical consideration, circulating free DNA contains circulating tumor DNA, and DNA coming from normal cell, especially from blood cells. So we need to be aware of clonal hematopoiesis, and a lot of attention has been put in recent years in the concept of tumor fraction that can be influenced by the disease type, the extent, and namely the tumor burden, and the tumor fraction is an element useful to understand the variant allele frequencies, and then we have some pre-analytical factor. Rapidly saying that clonal hematopoiesis can occur in gene of interest in cholangiocarcinoma, so EDH1, EDH2, and KRAS, and we need not to fall into this trap of chasing some mutations that are indeed linked to a kind of paraphysiological phenomenon. Moving to tumor fraction indeed is how much of the circulating free DNA come from the tumor, and biliary cancer are not among the most enriched, let's say, in tumor fraction, and tumor fraction can influence the detection of especially tumor mutational burden, MSI, gene amplification and deletion, meaning that when interpreting the report and looking for these 4 parameters, we need to be very careful about tumor fraction, and from a clinical standpoint, less tricky, but more impact, tumor burden impacts the detectability of alteration. Here again, example for lung cancer, the numbers of metastatic size influence the capability of detecting EGFR mutation, and even more interesting for this kind of audience, the difference, so the increase in the detection of something that is going on the blood in patients that have extrathoracic disease, so patients with only intrathoracic, so pulmonary, in this case, primary and metastatic disease, again in lung cancer, are not the best candidate to find something in the blood. And just the 2 final concept is be aware that a lot of elements that we see in the molecular report can be tricky to interpret. So also analyzing the kind of raw data from liquid biopsy in cholangiocarcinoma at progression to FGFR inhibitors, it occurred to me to find a lot of BRCA1 and 2 mutation. And the first reflex that a clinician can have is to call the pharmacist to have the PARP inhibitor off label, or to trigger a familiar counseling. Nevertheless, it turned out that a lot of these variations are unclassified, are not clonal, and are not pathogenic. And as a last concept, always be critical, because as liquid biopsy is a summary of what's going on across all the body, we can detect, we can have elements that come not from the primary disease, but from an occult disease. And so these are my take-home messages. We need to use liquid biopsy in this field right here, right now, when it can help therapeutic decision. Different technologies apply to different clinical settings. I would say we can discuss a lot about this in case-by-case scenario, that tissue biopsies are not enemies with liquid biopsy, but are indeed companions. And I've invented this kind of 5C rule, because results should always be interpreted as critically, clinically, in a careful way, in a collective way, so in a molecular tumor ball, and with calm. And indeed, we are between approvals, lesson from other diseases, and insights from the tissue. So we are in a kind of complex scenario. And finally, we don't have to be afraid to reach out for colleagues for advice. And with that, I'm really thankful for all of the people that helped me in this year to get knowledge in this field and not other. And I'm very, very proud and happy to be here at cholangiocarcinoma for the second time. It's a very good time here for me. Thank you.
Good. Thank you, Dr. Facchinetti, for that wonderful overview of the burgeoning area, which is liquid biopsy. I imagine there's tremendous interest both from patients, their families, and researchers alike. Up next, I have the pleasure of introducing Dr. Midhun Malla. Dr. Malla is at West Virginia University, where he's an assistant professor. He's going to be going to the University of Alabama, Birmingham in the summer. Dr. Malla has a tremendous track record of clinical and translational research in gastrointestinal cancers, including biliary tract cancers, and he will be speaking on the topic of how to incorporate these into clinical trials in design and implementation. So I'll turn it over to Midhun.
Thanks, Dr. Bourad. Appreciate the kind introduction, and thank you, the organizing committee, for for a fantastic program, and also for the opportunity. I'm honored and indeed delighted to share some insights and pretty much focusing on ctDNA in hepatobiliary cancers and how we can incorporate in clinical trial designs. And also, it's one of my favorite conferences, to share the stage and also the podium with patients, caregivers, esteemed leaders, and others in the field. All right. So here are my disclosures. So my talk is going to be focused on the applications of circulating tumor DNA across minimal residual disease, recurrence monitoring, response monitoring in advanced disease, molecular profiling, and tool for clinical matching, pretty much focused on, clinical setting in terms of, with the patient-centered approach, and how we can, envision future clinical trials in this space. Also cover limitations and some clinical trials towards the end. So circulating tumor DNA has multiple applications, as discussed a little earlier, and also by Francesco. And it has advantages being non-invasive or minimally invasive, and also have the opportunity to obtain repeated samples with minimal distress to the patient. Can cover tumor heterogeneity, both spatial, temporal heterogeneity, and also can be a good surrogate for tumor burden. Here are some brief characteristics of both tumor-informed and tumor-agnostic approaches that's covered in our article published in JCO. So, both have their unique characteristics. The tumor-informed approach requires tumor testing, and it takes a little longer for the first-time check with turnaround time about 4 to 6 weeks for the processing, but then the future checks could take about a week or less than 10 days. However, the tumor-uninformed approach is more of tumor-agnostic or plasma-only assay, where it does not require tumor testing, so the turnaround time is quicker. It's also important to understand, there are various platforms existing in this, current day-to-day practice. Understand, what they can offer, and at the same time also which setting they have more applicability is crucial. So let's delve right into the minimal residual disease and recurrence monitoring in this space. So I would start with the patient case. I would say one of my longest survivors of cholangiocarcinoma. Every time I see her, it brings great emotions in terms of joy and pleasure seeing her. It's a 76-year-old female. I first saw her when I started practice in 2019, presented with abdominal pain and jaundice with a bilirubin of 7.1. Imaging showed a 5x5 left hepatic lobe mass with extension into proximal right and left intrahepatic bile ducts, and FNA positive to be adenocarcinoma with some elevation of tumor markers as listed here. So she underwent upfront surgery, and pathology was consistent with poorly differentiated invasive intrahepatic cholangiocarcinoma with PT3NXM0. So her tumor marker declined postoperatively to 7, CA19-9, and she underwent 6 months of adjuvant capecitabine based off of BILCAP study. And by October 2020, the CA19-9 was also within normal limits based off of our testing platform at our institution's 32. So I started, enrolling her in the recurrence monitoring testing platform using a tumor-informed assay here. In October 2020, her mean tumor molecules per ml were 0.00. And I continued to monitor during this phase quite closely, both with CA19-9 imaging along with circulating tumor DNA. And I should plug in, a point here that it is, not current standard of practice, but at the same time, I wanted to, use that as a research and see how that, will help me manage my patients in a better way. So her circulating tumor DNA until November 4, 2022 is demonstrated to be 0.00, but however, in February, she started to see a spike or a detectable circulating tumor DNA, but her CA19-9 was within normal limits. So I started doubting the test to begin with first, but I just wanted to make sure, is it a true positive rather than a false positive. I repeated the test in a couple of months, and the trajectory is up and going, although the rate of increase is not as significant, but still is detectable, which caused some concern. So what is the data we have in terms of circulating tumor DNA within the MRD and recurrence monitoring? So we understand the limited sensitivity and specificity of the tumor markers we have in this space, and I was involved in a study where we included patients across hepatocellular carcinoma, gallbladder cancers, and cholangiocarcinomas. In about 151 patients used tumor-informed assay. It's a retrospective analysis of a prospective collection of circulating tumor DNA. And we found that ctDNA detection was associated with stage of disease with statistical significance, and also that MRD assessment or ctDNA clearance on therapy was found to be a valuable tool in identifying patients at high risk of recurrence. And more studies here, this is another study that looked at perioperative circulating tumor DNA analysis and found to have some predictive potential in liver cancers in about 97 patients that they used hybridization capture technique. 21 patients postoperatively were found to have detectable circulating tumor DNA, and 100% of them recurred with a disease-free survival of 5 months, whereas 76 patients were found to have negative circulating tumor DNA, and only 12 patients recurred with not reached disease-free survival. They found that detectable circulating tumor DNA and alpha-fetoprotein greater than 400 nanograms per ml in these patients with liver cancer, pretty much every patient relapsed. So let's continue on with our case. So with the suspicion of rising circulating tumor DNA, I have performed a CT chest, abdomen, pelvis. There was no radiographic evidence of disease recurrence. Then I changed the modality of imaging, obtained a PET CT scan, and the reading was listed in quotation marks here as metabolic foci adjacent to hepatectomy margin within a loop of bowel favored to be physiologic. And I continued to doubt whether is this really physiologic, looking at the PET scan here on the top right portion of the screen. Presented her case in the multidisciplinary tumor board. We had fun discussions, mixed opinions in terms of how to approach this, but I thanks to our advanced GI team, at my request, they have proceeded with an endoscopic ultrasound which showed a hyperechoic suspected mass adjacent to the liver site, likely site of previous hepatectomy, and pathology positive for poorly differentiated carcinoma. So she was started on chemotherapy. By November 2022, it trended down to 0.00, and she completed chemoradiation because being it's the local site of disease, and CT chest, abdomen, pelvis as of 2 days ago showed no evidence of disease recurrence. So this testing platform, the tumor-informed testing platform, has given me ability to treat a patient, with loco-regional approaches, earlier in the setting. But I think what remains to be seen is whether this can prolong the patient's survival in the long term is yet to be seen in a prospective clinical trials. So how can we incorporate this into a clinical trial? Obviously, we need prospective evaluation. We need more studies, evaluating this, with focused attention and also being as a primary endpoint in either neoadjuvant disease settings or adjuvant disease space in across MRD setting or recurrence monitoring. And the designs can be prospective observational studies or escalation, de-escalation studies with the primary endpoint of disease-free survival. And we can learn from our colorectal cancer colleagues and the disease space where they have NRG-J005 in a COBRA study where they're using a tumor-agnostic testing platform, randomizing patients to standard of care therapy versus assay-directed therapy. And I think most of us are aware of this dynamic study design, which is in the process of changing the landscape of how stage 2 colon cancers is managed. And here are various styles or how clinical trials can be designed. It's just not not one approach can fit all. It depends on the setting, which really matters. Moving on to the immunotherapy response monitoring. We all know the significant strides that immunotherapy made in both hepatobiliary cancers in the frontline space. I think every patient should be offered and discussed about immunotherapy in both HCC and biliary tract carcinomas. And these are the Kaplan-Meier curves of progression-free survival across the 3 landmark studies. They were significant. However, I want groups focused attention towards the the red circles here. So there is this cohort of patients who perhaps wouldn't benefit from the immunotherapy, and we still don't know who are those, right? And as you can see, within the first 3 to 6 months, there is a significant drop in the progression-free survival, suggestive of the need for predictive biomarkers in this disease setting, as standard radiological criteria do not consistently capture the dynamics of clinical benefit. And as discussed previously, repeated tumor biopsies is not practically feasible. So this is the data from the frontline atezobev from IMREV 150. In fact, only 30% of the patient population were responders, and they had very excellent long-term survival, greater than 20 months. About 20-25% of the patients had progressive disease. Only 50% survived at 4 months, and 50% had stable disease with median overall survival of 13 months. And what's more enlightening is the fact that by 20 months, both stable disease and progressive disease patients had similar median overall survival. When we look at the study as an overall analysis, I think this would be hard to delineate, and that's where I think we need to understand and identify the non-responders to atezobev or to any immunotherapy combination to that matter, because they represent an unfavorable population. So this is a study that, in 47 patients, they looked at on-treatment circulating tumor DNA who received atezobev, in a phase 1b study, and those patients who had circulating tumor DNA clearance at cycle 4 at 9 weeks was associated with favorable survival, as demonstrated here, and also shown to have correlation with objective response rates, and lower post-treatment ctDNA changes correlates with survival as early as cycle 2, day 1, which is 3 weeks into the treatment. So to elaborate more on this, so there is a proof of concept study that looked at ctDNA being a prognostic and predictive biomarker in those patients treated with immune checkpoint blockade across 3-phase 1 or 2 trials using durvalumab and tremelimumab in about 1,000 patients. And here is the distribution of the patient population. This is advanced cancers, not specific to cholangio or hepatocellular carcinomas, but that population contribute about 40 patients among 978 patients. And in this study, they found pre-treatment variant allele fraction was found to be prognostic, and on-treatment variant allele fraction was found to be both predictive of response to treatment and prognostic of response to treatment. They have defined molecular response as a ratio of on-treatment VAF to pre-treatment VAF, and molecular response was defined as something with greater than 50% response in VAF, and they clearly found that an association with objective response rates to molecular response. And the point of more interest here is, what to do with these patients that we see in the clinic that have radiological stable disease at 9 weeks assessment into the treatment. They had about 73 patients who had stable disease as the first scan results, and out of which 76%, like 19 out of 25 patients that went on to have a partial response were found to have a molecular response, and ctDNA predated achieving radiological response by a median of 8 weeks. And molecular response was demonstrated or associated with improved progression-free survival and overall survival. Here is another one of my favorite studies in this space, that used personalized ctDNA analysis as a predictive biomarker, in patients who received pembrolizumab, and analysis with every 3 cycles of treatment and also at baseline. They used a bespoke analysis here. Once again, goes with the discussion here is baseline ctDNA was found to be sensitive and prognostic. ctDNA delta from baseline to cycle 3 is also prognostic, and ctDNA clearance was associated with objective response rate. So clearly there is a theme here that there is molecular response need to be taken into consideration when we treat these patients in addition to clinical response along with radiological response. And more interestingly in this study that they compared patients who had raising ctDNA and a response in the scans and fallen ctDNA and who had progressive disease. And I want to focus the attention here to the middle 2 curves here, the green is increased ctDNA, but they had found to have response in the scans. In fact, they did inferiorly when compared to the patients who had decreased ctDNA but progressive disease on the scans. And this is something of fascinating to me, but it's definitely a subset analysis, and we need more prospective studies here. So combining the RECIST responses and the ctDNA response at first scan at 9 weeks, it certainly refines the the risk categorization here into ctDNA positive and negative, and it identifies an unfavorable population at high risk for and poor survival. So, ctDNA here can be used for longitudinal monitoring and early determination of responders. And with this background, me and my partner in crime in the ctDNA space, Dr. Gentry King, designed a randomized trial of switch of therapy from atezo-bev to lenvatinib, perhaps, when they had unfavorable ctDNA. And we presented the concept to the task force about a couple of years ago. Although there was more interest in this space, but I think the feedback we received was we need more feasibility, we need more prospective data in this cohort, and after which we modified the study into identifying patients at RECIST stable disease into molecular non-responders and responders, and continuing the same regimen in this space and see how with the primary endpoint of PFS1. We are yet to find support for this study, and this is still currently in our desktops with no movement there, but we would always appreciate collaboration and funding in this instance to move this important studies like this forward. How about ctDNA and molecular profiling and spatial and temporal heterogeneity? I'll try to keep this as simple here, because I think we have already covered this. In the Phoenix study, futibatinib has received FDA approval for FGFR2 rearranged intrahepatic cholangiocarcinoma. But thanks to the efforts of Dr. Goyal and her team, I think they found 87% positive percentage agreement with liquid biopsy and the tissue biopsy. And interestingly, 3 patients with FGFR2 fusion positive intrahepatic cholangio, they've found to have a short interval progression of disease due to secondary kinase domain mutations. So as seen here, this is patient number 1 who had treatment response, short interval progression, tumor biopsy showed 3 alterations, and which were all found in the liquid biopsy, in fact, in a few more. And that theme continues across the 3 patients here, and which supports the immense potential that this tool has, to use in our armamentarium. And lastly, clinical trial matching tool. I think we strive to prolong survival of our patients, and in the clinic, I think this is one of my challenges, to identify and clinical trial and how can I match, my patient in front of me to a trial, across the nation. And one of the few challenges listed here for biomarker targeted clinical trials, it being multiple action targets, but only fraction of patients, genotyping cost, and there are of course a lot of barriers, and that's where we need to use the liquid biopsy in this space. And taking guidance from Scrum Japan, which is a registry, is where they had longitudinal prospective observational collection of studies across 71 core cancer institutions, gathering real-world data on advanced solid tumors with rare alterations. And here they assess ctDNA-based genetic testing and have both tumor-specific and tumor-agnostic in advanced tumors, and try to find clinical trial matching for these patients. And I've tried to gather the data and create a table here. Like on the left, you have GI screen data, and on the right is Godzilla, where they have used tissue-based testing and plasma-based testing, respectively. And here clearly we can see that sample unavailability rate, sample failure rate, and median sample acquisition duration were all significantly lower with liquid biopsy approach, while at the same time, ctDNA genotyping led to statistically significant increase in clinical trial enrollment with no compromise in the survival analysis. So once again, suggestive of the fact that it should be considered, to identify patients and also to increase clinical trial accrual. Finally, in a few seconds here to talk about limitations, we got to be really cautious about identifying patients with false negatives. Site of metastasis clearly is important. Lung and peritoneal metastasis seem to be, the concordance is low with 65 and 56% when compared to the liver metastasis with about 96% concordance. And when we have patients with increased cell-free DNA in the background, it can, show false negative results. And insufficient ctDNA sample or assay sensitivity, and also limited detection of fusion events. So it's right, important to understand the platforms that are available. False positives, as covered previously, chip mutations, sequencing errors, and in those patients who have history of transplantation and greater than 1 cancer, so I tend not to use them in my practice. So clearly, again, setting of ctDNA assessment is key. So I've tried to look at clinicaltrial.gov and try to see whether there are focused clinical trials, just using ctDNA in terms of, change ctDNA guided management, and I was a little disappointed to not see them yet, and I would really like to see and envision this in the next few years, changing, the track in terms of, focused attention similar to colorectal cancer space here. So finally, I'd like to conclude my talk that ctDNA is certainly a promising and emerging, non-invasive prognostic biomarker with multiple clinical applications. It also can have substantial applications in drug development to provide more assessment of benefit in early phase clinical trials. It is not here to replace a tissue biopsy, not here to replace imaging, but it's certainly an adjunct marker that can complement radiological assessments. And after, thoroughly understanding the limitations, it certainly has immense potential to propel, precision medicine. And I think what we need is multi-institutional collaborations, with prospective clinical trials, and always happy to be involved in those. And I once again thank you for the opportunity.
Okay. Thank you, Dr. Malla, for that very nice overview on how clinical trials are beginning to incorporate these very exciting technologies, and of course for patients this is a big blessing. Last but not least, we have Dr. Pedro Rodrigues from Biodinista Institute in San Sebastian, where he's a principal investigator, and he will be giving us some insights into how these technologies will be applied to earlier in the management of the disease, early diagnosis specifically.
Good afternoon, everyone. Thank you very much, Dr. Borad, for this kind introduction. And first of all, I would like to thank the scientific committee and the organizing committee and the Cholangiocarcinoma Foundation for this kind invitation. It's for me a huge pleasure to be in this excellent and inspiring meeting. So thank you very much. So I will talk a little bit about the role of liquid biopsy in the early diagnosis of cholangiocarcinoma beyond circulating tumor DNA. So as you all may know, the diagnosis of cholangiocarcinoma may be an incidental finding in up to 25% of cases. But still, some patients may present non-specific symptoms such as jaundice, fever, severe weight loss, fatigue, or abdominal pain. Currently, the diagnosis of cholangiocarcinoma is achieved by combining imaging techniques with the measurement of non-specific tumor biomarkers in serum such as CA99, and also with tumor biopsy, which is usually mandatory to confirm the diagnosis. However, imaging techniques have some limitations, since sometimes they are not always accurate enough to allow the early diagnosis of cholangiocarcinoma, and also with an imaging technique may be difficult if we are facing a stricture to differentiate if this stricture is malignant or benign. In addition, non-specific tumor biomarkers, they have low accuracy, and up to 10% of the general population are unable to express CA99 due to inactivating mutations in FUT3 gene, and also some patients with primary sclerosing cholangitis, a condition that increases the risk of cholangiocarcinoma development, also display increased serum levels of CA99, which raises some concerns in the useless of this tumor biomarker. On the other hand, tumor biopsy is accurate, but is an invasive procedure with inherent risks. Therefore, there's an urgent need to find new, accurate, non-invasive biomarkers for the early diagnosis of cholangiocarcinoma. So liquid biopsy has emerged as a promising strategy to find biomarkers in cancer, since they may allow the screening of patients, the early diagnosis, stratify patients, guide therapeutic decisions, also monitor treatment response, the presence of minimal residual disease, and also predict relapse or prognosis, being a useful tool in precision medicine. So when we are facing patients with high-risk high-risk conditions that predispose for cholangiocarcinoma development, a clinical question that may arise is, can we predict which patients will develop cholangiocarcinoma during lifetime? And also, when we are facing a stricture, can we differentiate if they are benign or malignant? Therefore, these biomarkers may allow to predict the patients that will develop CCA during lifetime and establish screening programs that allow the early detection of cholangiocarcinoma. So in this sense, several liquid biopsy approaches were already searched in the last decades. Circulating tumor DNA was already discussed. I will focus in the other ones now, and starting with microRNAs, for example. MicroRNAs are small non-coding RNAs that negatively regulate gene expression in a post-transcription manner. And apart from their role in disease pathogenesis, they also harbor an ability to be used as biomarkers, and particularly microRNA signatures were already found in biofluids of patients with cholangiocarcinoma. And in this sense, two meta-analyses have already studied the potential diagnostic value of microRNAs with a pooled area under the curve value of 0.9 in both of the studies. Nevertheless, the diagnostic capacity of microRNAs is different according to the biological fluid that is being studied. And for instance, bile was the fluid that harbored the highest diagnostic capacity, followed by serum and plasma, and then tissue and urine. This table summarizes some of the microRNAs in biofluids that were studied already in bile, serum, and urine in patients with cholangiocarcinoma. And for example, MIR9 and MIR145 were the ones in bile that harbored the highest diagnostic capacity for the diagnosis of cholangiocarcinoma. Another example is the oncomicroRNA MIR21, which was shown in different studies to be increased in serum or plasma, or even in urine in patients with cholangiocarcinoma. And these were single studies, and this recent study published from a Copenhagen group, the Professor Jesper Andersen's group, in which they evaluated and profiled all the microRNAs in whole blood of more than 200 patients with biliary tract cancer. They observed that there was a disruption in the expression profile of the microRNAs in patients with biliary tract cancer, and after a univariate analysis, they observed that 4 microRNAs were increased in the circulating biofluids, serum or plasma, in patients with biliary tract cancer. And when they combined them in an index, they observed that this index allowed the diagnosis of patients with biliary tract cancer with very good area under the curves in both discovery and validation cohorts with similar values to the ones of CA99. But most importantly, when they combined this index with CA99, the diagnostic capacity increased and overpowered the one for CA99. Another approach is the measurement of extracellular vesicles. What are extracellular vesicles? They are small membrane spheres that are secreted by all the cells into the extracellular milieu, and they are present in all the biological fluids, such as blood and urine. And there are different types that are categorized according to their origin, their size, their molecular composition, and their biological function. These extracellular vesicles, they have different biomolecules, such as proteins and metabolites, nucleic acids and lipids, that may be used as useful biomarkers to diagnose diseases and cancer. And starting with proteins, 7 years ago, we decided to evaluate the proteomic profile of isolated serum extracellular vesicles from patients with hepatocellular carcinoma or cholangiocarcinoma compared to control individuals. And we observed that a distinct proteomic profile was present in EVs from patients with HCC or CCA that allowed the early end diagnosis of these two types of primary liver cancer. And more importantly, they were able to distinguish between patients with HCC and intrahepatic cholangiocarcinoma, which is currently a major clinical challenge. And in a sense, we are able to observe that 6 proteins here in gray harbored a very good area under the curve value that was better to the ones provided by CA99 or serum AFP levels that are routinely used for the differential diagnosis of iCCA or HCC. Next, we wondered if we could also measure proteins in serum extracellular vesicles that could allow us to diagnose cholangiocarcinoma in patients at high risk for the development of bile duct cancer, such as patients with PSC. And we questioned if these proteins could allow the early diagnosis of cholangiocarcinoma in these patients and also determine the risk of patients with PSC to develop cholangiocarcinoma. We decided to follow the same strategy, similar to the one in 2017. So we isolated serum extracellular vesicle from patients with PSC and from patients with concomitant PSC and cholangiocarcinoma and compared the proteomic profile to healthy individuals. And in this discovery cohort, we observed that there were several proteins that were allowed the specific diagnosis of PSC cholangiocarcinoma compared to isolated PSC with area under the curve values higher than 0.9. We then asked ourselves if these candidate EV biomarkers are etiology related, I mean, if they will only be useful for the specific diagnosis of PSC cholangiocarcinoma, or either if they could be used to the diagnosis of cholangiocarcinoma independent of disease etiology, here named as pan-cholangiocarcinomas. And to do so, we decided to validate our results, increase our cohort of patients, including more patients with PSC, more patients with PSC cholangiocarcinoma, reaching a cohort number of 42 patients, and also including patients with cholangiocarcinoma arising in a non-PSC etiology. We measured the proteomic profile of these serum extracellular vesicles in a new and more powerful mass spectrometer, and we observed that 5 proteins were specifically used for the diagnosis of PSC cholangiocarcinoma, while 7 proteins were more useful for the diagnosis of cholangiocarcinoma arising in a non-PSC etiology. But most importantly, we observed that almost all the remaining proteins could help us to diagnose cholangiocarcinoma independent on disease etiology. We next question if we could measure these proteins in total serum, avoiding the isolation steps of extracellular vesicles. So we first decide to measure by immunoblotting some of the proteins in the proteomic analysis with the highest diagnostic capacities, comparing their expression in isolated serum extracellular vesicles, in serum that was depleted from extracellular vesicles, and in total serum. And as you can see here, most of the selected proteins were highly enriched in isolated extracellular vesicles and increased in cholangiocarcinoma when compared with healthy individuals, but most importantly, these proteins were able to be detected in total serum. This led us to question, can we then use a technique to measure these proteins that could be used in clinical practice? And then we decided to measure these proteins using a ELISA technique. And we were able to validate our findings and observe that all of these 7 proteins were increased in the serum of patients with PSC cholangiocarcinoma and also in patients with non-PSC cholangiocarcinoma compared with either PSC or healthy controls. We then combined these proteins in logistic models to increase their diagnostic capacity, and we observed that the combination of only 2 proteins, CRP and FRIL, for example, allowed the diagnosis of cholangiocarcinoma independent of disease etiology with very good area under the curve values in training and testing cohorts, and most importantly, the diagnostic capacity of this panel increased when we only considered patients with early CCA. Similarly, when PSC was confirmed, the combination of only 2 or 3 proteins allowed the diagnosis of cholangiocarcinoma with very good area under the curve values. And we observed that when we combined these panels with CA99, we were able to overpower the current diagnostic capacity of CA99 alone. We next question if we could also discriminate patients with HCC and intrahepatic cholangiocarcinoma. And we decided then to measure the levels of all of these biomarkers, including now patients with HCC, and compare them with intrahepatic cholangiocarcinoma. And we observed that all of these biomarkers were increased in patients with intrahepatic cholangiocarcinoma compared with HCC, obtaining very good area under the curve values. And the combination of only 2 of these biomarkers allowed to obtain an area under the curve value of 0.96 for the differential diagnosis of these 2 types of primary liver cancer. We next question if we could identify which would be the organ of origin that may be secreting these biomarkers into circulation. So we decided to evaluate a multi-organ RNA sequencing data set that is present in the Human Protein Atlas that contains data from 61 tissues and organs, and we observed that all of these biomarkers were mostly expressed in hepatobiliary tissues, here in green or red. Also confirming, we used single-cell RNA sequencing from normal liver, and you observed that the candidate biomarkers were expressed in different cell types, but mostly in hepatocytes or cholangiocytes. We then moved to human CCA tumors, and we would like to confirm which cell types within these tumors are expressing these biomarkers, and we evaluated which cell types in these tumors are secreting them. So we observed that most of these biomarkers were expressed in malignant cholangiocytes here, and for example, another 2 of them, WOI3 or VWF, were mostly expressed in non-parenchymal cells, mostly in endothelial cells. We validated these results by measuring their expression with immunofluorescence in tissues from human patients with CCA or PSC-CCA compared to PSC, and we observed that the expression of these biomarkers was markedly increased in the tissue of patients with CCA and PSC-CCA compared with controls, and most importantly, there was a co-localization of the signal of these biomarkers with the expression of CK19, which is a marker of cholangiocytes. Therefore, we conclude that the cells that are actively secreting these biomarkers or actively expressing these biomarkers are malignant cholangiocytes. We next question if these biomarkers may allow the prediction of cholangiocarcinoma development in patients with PSC, and to do so, we included a new group of patients which are patients with PSC that developed cholangiocarcinoma during follow-up, but that we collected the sample before any clinical evidence of malignancy, and we call the group of the PSC2-CCA group. And you observe that the levels of these 4 biomarkers were increased in the PSC2-CCA group when compared with PSC. And most importantly, when we measured the levels of these biomarkers in the serum of these patients, we observed that 100% of patients that presented alterations in 4 of these biomarkers developed cholangiocarcinoma during follow-up, while, on the other hand, all the patients that did not present any alterations on these biomarkers developed cholangiocarcinoma during lifetime. We then combine these biomarkers, and you observe that only the combination of 2 or 3 biomarkers provided a very good area under the curve values for the prediction of cholangiocarcinoma development with PSC, overpowering the predictive capacity of CA99. Finally, we asked ourselves if these serum EV proteins could also have a prognostic value. And after a multivariable analysis, you observe that 9 proteins had an independent prognostic value for overall survival in patients with cholangiocarcinoma. 5 of them were considered bad prognostic biomarkers, meaning that increased levels of these biomarkers were associated with worse overall survival. And on the other hand, we had 4 good prognostic biomarkers, meaning that lower levels of these proteins were indicative of a worse prognosis. We then combined them, and we observed that, for example, patients harboring elevations in 2 or 3 of these biomarkers displayed a worse overall survival with a median overall survival of 5 months when compared with patients that displayed no elevations on any of these 3 biomarkers that displayed a median overall survival of 102 months. On the other hand, the same was true for the good prognostic biomarkers. So in conclusions of this part, we saw that serum extracellular vesicles contain accurate proteins that may be used as early and non-invasive biomarkers for CCA and may be etiology-specific. We also find predictive biomarkers of CCA development that are amenable to be detected in total serum. Several of these identified liquid biopsy biomarkers are expressed in malignant cells within the tumor, and the levels of these protein biomarkers may also have a prognostic value that is independent of other clinical variables. What happened with nucleic acids? We decided to evaluate the transcriptomic profile of serum and urine extracellular vesicles from patients with cholangiocarcinoma. In this sense, we isolated extracellular vesicles from both blood and urine from patients with cholangiocarcinoma, PSC, ulcerative colitis, and healthy individuals. We evaluated their transcriptomic profile and compared the obtained transcriptomic profile with human CCA tissues from 2 independent cohorts of patients. Then we compared the profile with the transcriptomic profile of CCA cells in culture and also with the extracellular vesicles that are secreted by these cells. So we characterized the extracellular vesicles, both the serum and urine extracellular vesicles, and we observed that these vesicles were expressed as typical markers of extracellular vesicles and observed no difference between groups regarding the concentration and the size of the extracellular vesicles. And after measuring the transcriptomic profile of these vesicles, we observed that patients with cholangiocarcinoma displayed a higher number of transcripts, both mRNA and non-coding RNAs, when compared to the patients included in the other groups. And when you compare the biomarkers, you observe that several transcripts harbored a highest diagnostic capacity for the diagnosis of cholangiocarcinoma compared to the other patients, with some of the transcripts reaching the maximum diagnostic capacity for the diagnosis of cholangiocarcinoma. We then compared the transcriptomic profile with the ones from 2 independent cohorts of patients, and we were able to observe that 479 transcripts were commonly changed in the tumor and in the extracellular vesicles. We compared this profile with the one obtained from CCA cells in culture, and we observed that 156 transcripts were commonly altered, and finally 105 transcripts were commonly altered in the extracellular vesicles derived from these cells. We decided to measure in which processes are these 106 transcripts involved, and we observed that most of these transcripts are involved in processes that are important during oncogenesis and malignant transformation, such as cell cycle, cell growth, and regulation of cell adhesion and communication. So as an example of the final liquid biopsy candidates, we observed that, for example, CEMIP or GAD1 are increased in serum extracellular vesicles from patients with CCA, are increased in tumor tissue from patients with CCA compared to surrounding liver, are increased in CCA cells in culture, and also in the extracellular vesicles secreted by these cells. These final liquid biopsy candidates harbored a very good area under the curve value for the diagnosis of cholangiocarcinoma, and the combination of only 3 of them provided the maximum diagnostic capacity for cholangiocarcinoma. We followed the same strategy for urine, ending up with these 2 liquid biopsy biomarkers that, when combined, provide an AUC value of 0.8. So as conclusion of this second study, we observed that serum and urine extracellular vesicles from patients with cholangiocarcinoma contain different RNA profiles that compared to healthy individuals and patients with PSC or UC. Some of these RNA molecules could be used as diagnostic biomarkers for CCA, and some of these biomarkers may mirror the expression in tumor tissue and may potentially play a role during cholangiocarcinogenesis. Therefore, these RNA molecules in serum and urine extracellular vesicles constitute a promising liquid biopsy approach for CCA diagnosis. I'd like only to finish with explaining a little bit about metabolites. And we, 3 or 4 years ago, we evaluated the metabolomic profile of serum from patients with intrahepatic cholangiocarcinoma, HCC, or PSC, and we observed that, for example, when comparing intrahepatic cholangiocarcinoma with control patients, 52 metabolites were changed, and 12 of them provided an area under the curve value that were higher than the one obtained for CA99. The same was true for HCC when compared with intrahepatic cholangiocarcinoma, and also for intrahepatic cholangiocarcinoma in patients with PSC. So these allow us to construct novel models, and for example, as you can see here, the simple combination of 6 metabolites provided an area under the curve value of 0.9 in discovery cohort and 0.981 in validation cohorts for the differential diagnosis of intrahepatic cholangiocarcinoma and HCC. And the same was true for intrahepatic cholangiocarcinoma and PSC, in which the combination of 2 metabolites allowed us to differentiate these 2 types of liver diseases. So the combination of different metabolites provided an excellent diagnostic capacity for the differential detection of the 2 main types of primary liver cancer, and also to detect ECCA compared to PSC. The final question is, can we also predict and early detect CCA in patients with PSC using metabolomics? And this is a study that we are currently conducting, in which we use samples from 5 different types of patients. We are including samples from patients with isolated PSC that we know that did not develop any type of cancer in at least 5 years of follow-up. We are including patients in the PSC2-CCA group, patients with PSC and CCA, and also patients with PSC that underwent liver transplantation and experienced or not disease recurrence. We evaluated the serum metabolomic profile in collaboration with several international collaborators from the International PSC Study Group. And as a preliminary result in the discovery phase, we observed that when comparing patients with PSC cholangiocarcinoma and PSC, there was a completely altered serum metabolomic profile that may allow the diagnosis of PSC cholangiocarcinoma. What was more surprising is that when we compared the patients with PSC that developed cholangiocarcinoma in the follow-up, the metabolomic profile was mostly similar to the one observed in PSC cholangiocarcinoma, which may suggest that the changes in the metabolomic profile may be already present when the clinical evidence of malignancy is still absent. We are now conducting the validation phase, and we hope we can present the results soon. So in concluding, we observe that different diagnostic and prognostic methodologies represent an emerging and stimulating field of research in hepatobiliary pathobiology that harbor multiple potential applications from biomarker discovery to therapy. These new candidate biomarkers now need to be internationally validated using easily transferable techniques and using raw biological fluids. And in this sense, I invite you, every one of you who wants to participate in this validation. We are currently validating the proteomic results. You can talk with us, with me, or with Professor Jesus Banales. Contact us if you want to participate with samples in the validation phase. We will be very happy to include in this study and validate our results. We must say that appropriate clinical relevant control groups with biopsy-proven diagnosis are needed, and it is also urgent to discover and validate new biomarkers of treatment response. In addition, these biomarkers may be useful for the diagnosis, but they also have a role in disease pathogenesis, and we could evaluate their potential clinical application to find novel therapeutic targets. I would like to thank all the institutions that are funding our work and our research group in San Sebastian. And thank you very much for your attention.
Okay, thank you, Dr. Rodrigues, for that tour de force on things beyond DNA, microRNA, metabolites, proteins. I think you covered almost everything we could have imagined there. So time now for interactive discussion. I think we want to see if there's questions from the audience. If we could, I guess, have the lights on and the microphones available.
Congratulations, Pedro, congratulations for this very beautiful talk, of course, but I want to comment specifically on what you are going to see and you already see, but especially in metabolites. Because what probably you know, but what we have discussed with Guido Carpino is that in PSC cholangio, the kind of carcinogenesis follow the so-called field cancerization pattern. What is this? Is a metachron development of dysplasia and cancer in a different part of the biliary tree, practically everywhere. So what this means? This means that you don't need to have the mass, the cancer like a mass, but the dysplasia and the very early cholangio, probably as you said, is already there and produce the metabolites. I think this is very informative for your study.
Yes. Thank you for your comment. As I mentioned, we already saw differences in the patients that developed cholangiocarcinoma during the follow-up, but that did not add a tumor in the time of sampling. But we can't rule out that the tumor was not there, or at least some malignant stricture, because the thing we only know that at sampling there was no clinical evidence of malignancy. What would be great now is after, when we validate these findings, have different samples from different stages of progression of PSC and try to identify in which time point or in which period of the development of cholangiocarcinoma are these metabolic changes happening, to identify when can we be helpful to diagnose cholangiocarcinoma and define the screening programs for these patients.
Congratulations.
Are there any other questions? Yes.
I had asked some questions earlier about the Signatera, and my husband has been doing it. I think you've done it 4 times, and it was 0 each time. But at Duke, they said there's no need to continue doing it. And so what you said, that as you watch the patient, you saw it go up. So how often would you do that? And then I have a couple of other questions.
Yeah, thanks for bringing up that practical question. You know, I think this is completely out of data-free zone. I mean, not in the guidelines, but I think I try to use that platform, especially in the MRD setting, like patients who completed the surgery or in their adjuvant space, while we monitor them with scans and tumor markers, which I, have a lot of respect, but at the same time, not have a lot of respect at the same time, especially with the tumor markers with their limited sensitivity and specificity. The key point of the circulating tumor DNA testing is longitudinal monitoring, and more times we order, that sensitivity and specificity increases. For example, one-time testing only has 68 to 70% sensitivity. However, longitudinal testing report more than 3 to 4 times testing has led to greater than 90% sensitivity and specificity. So I usually combine those assessment with their every 3-month visits together with the scans, clinical exam, and tumor markers as an adjunctive, response, like molecular response assessment.
Okay. And then in 2016, I was introduced to the RGCC from Greece to monitor breast cancer, which I had in 2011. And I had been told I was cancer-free and did that test, and my circulating tumors were 7.7, so they were high. So I did have something going on. Now they, over 8 years, it's 2.2. There's so much information there, and I didn't understand it. I don't understand a lot of what you said, but a lot of the genetic studies, there's a lot in that Greece test. And Greg has done it, and his numbers before surgery were 5.8, and then after surgery, they went down a little bit, and then now they're 3.8 for the circulating tumor cells. But it has all this, all the numbers. It had the P53, but we didn't know what to do with that information. And we've shown it to all of our doctors, But is there anybody who would take those results and could explain or put it, I have 8 years of results, and he has 3. But there's also another thing where you actually, with the blood, it's called SOT, and he gets an infusion that's made from his blood, and it goes after the DNA of cancer. And we do that twice a year. So those are just things, but it's called the RGCC from Greece. And insurance doesn't cover it, and FDA, but there's good information. It's lots and lots of information from that lab. And it's called the Research Genetic Cancer Center in Greece, is what we've used. So I just have lots of questions.
Yeah, no, thanks for bringing it up. I mean, I'm not familiar with the testing platform, but we'll be happy to, meet after the session and, discuss more thoughts and insights there. But thanks for bringing it up.
A question for the panel here. With somewhat less common cancers, and we're learning cholangiocarcinoma is not that uncommon, but nevertheless, the field for early detection seems to be moving more and more into multi-cancer or pan-cancer detection, MSED or PSED as people call it. So maybe Dr. Rodrigues and others, if you could comment on available tests right now. Could they be applied for cholangiocarcinoma? What are your thoughts on that?
Available tests. We have the foundation one to try to find the mutations, but it would be difficult to try if the patient has not the mutation for the diagnosis. It would be difficult. There are some tests not for cancer yet, but for example, there are already some tests that are based in the specific metabolites that are used, for example, for non-alcoholic fatty liver disease. We hope that with our studies in the future, we can apply this type of devices for the diagnosis of cholangiocarcinoma, for example.
There's also the Grail-Galleri test. Is that something available in the EU? And in the US, it's available, not FDA approved. So I'm wondering if people have any examples from the panel of use cases or? Yes,
I can add something. I attended a conference that it was a leading person in Illumina explaining all this setting of a kind of early diagnosis or even screening that is real complex, and this applies good to my talk because we are moving to a setting of whole genome sequencing on blood. So we are really expanding the coverage. So we cover from one single mutation to all the exome and all non-coding region to find really signatures that can predict the development of disease, and all the, let's say, all the big companies are moving in that field, and because it's kind of a good market, but it's not even clinical, but from a social perspective, it requires a lot of data, a lot of patients, and especially a lot of follow-up if we think about this test as a screening, and it's a really complex scenario.
I think we are running late and we have just time for one last question.
Hi, you had mentioned earlier on one of your slides, you had the DNM T3A on one of your slides, and you mentioned clonal hematopoiesis. Can you just kind of explain that a little bit further, if you would?
Yes. So TNMTA are, I show them in one slide, that are frequently mutated in are mutation found in clonal hematopoiesis of indeterminate potential. So this can be either an event linked to the tumor, so coming from the tumor, or if found exclusively on the tumor biopsy or on ctDNA, an event that has nothing to do with the tumor, and we have not to chase it from a clinical point of view, but we need to take into consideration that it's there, and it could mean something else from more an hematologic point of view. So it's, my message was to be aware that not all we see in the liquid biopsy come from the tumor, even some signatures that could mimic elements, molecular element coming from the tumor. So evoking the need to be careful and critical with the results.
Okay. Thank you very much. I'm sure that the speakers will be available after the session for continuing the discussion. So we'll now close this session.